So my role today is to explain to you when to suspect the disease and how to treat the disease. This lecture is based on several publications that we wrote about the topic. So we know that tuberculosis is re-emerging as a global health problem, and the number of patients is increasing. This table shows you the prevalence of tuberculosis uveitis among large uveitic cells from different parts of the world. And you can see in Saudi Arabia, like in a paper by Professor Tabara, was 10.5%. And more recently, in our publication, the number with tuberculosis uveitis was even more. So Vogt-Honecker-Harada disease accounted for about 20%, tuberculosis uveitis 17.8%. And this is based on this publication. So tuberculosis uveitis in recent years is increasing. What you need to keep in mind also that you can have ocular involvement without pulmonary disease. This is extrapulmonary disease. And the absence of clinically evident pulmonary tuberculosis does not rule out the possibility of ocular tuberculosis. That's why we had a lot of discussions with our medical group when we want to try to treat a patient with anti-tuberculosis treatment. They said, oh, but the patient does not have systemic tuberculosis. We can have pulmonary ocular tuberculosis without systemic involvement. So absence of clinically evident pulmonary tuberculosis does not rule out the possibility of tuberculosis, as about 6% of patients with extrapulmonary tuberculosis has no evidence of pulmonary TB. So you can have tuberculosis localized only to the eye. So what are the diagnostic criteria that over the years we use to diagnose the disease? First of all, you need to see ocular finding consistent with possible tuberculosis, as I shall discuss with you now, with no other causes of specific uveitic entities, such as, for example, Behçet or Vikage. So if the patient had mouth ulcers, genital ulcers, and inflammation consistent with Behçet disease, so this is Behçet disease. We also rely still a lot about tuberculin skin test. And in our experience, strongly positive tuberculin skin test is highly suggestive of the disease. We mean by induration, not hyperemia, not erythema. Induration 15 millimeter or more with or without necrosis. And last, response to anti-tuberculosis treatment with the absence of recurrence after the patient complete anti-tuberculosis treatment. It is of help to have a family of a history of exposure to patient with tuberculosis or family history of tuberculosis. It will help if you have this history. So tuberculin skin testing is of major importance to provide supportive information when clinical signs or symptoms suggest tuberculosis. And we depend on the size of the reaction, history of exposure, regional prevalence of atypical mycobacteria, and patient characteristics such as age and immune status. In meetings, when I used to talk about tuberculosis uveitis, it comes a common question, but how about BCG vaccination? Countries in which BCG vaccination is done, the patient can have a positive BBD skin test. And the answer is that the effect of BCG vaccination on tuberculin skin test declines over the first 7 years of life. And then it has no effect. And an induration which is more than 14 millimeter is very unlikely to be due to BCG vaccination. So this is the answer. If you have a patient with 20 millimeter induration, this is not BCG vaccination. because the effect of BCG vaccination on tuberculosis skin test declines and then disappear after 7 years of life. In our study of 114 patients with presumed tuberculosis uveitis, the mean area of induration was 24 millimeter, so it's very large. And in addition, previous studies, clinical studies, they put a lot of emphasis on the importance of tuberculosis skin test as indirect evidence of presumed tuberculosis uveitis. Now then comes the more recently available interferon gamma release assays. Anyone knows how does this investigation works and why it is called interferon gamma release assays? So interferon gamma release assays, these are based on collecting a blood sample, separating the blood cells, exposing the blood cells of the patient to 2 antigens specific to Mycobacterium tuberculosis. And then you measure by ELISA the amount of interferon gamma released. Because if the blood cells, if the immune cells of the patient are exposed to Mycobacterium tuberculosis, they will react to these antigens by releasing interferon gamma. And as I discussed previously, interferon gamma is an important product of T helper 1 lymphocytes. So that's why it is called interferon gamma release assays. So interferon gamma release assays are also available. We always do both tuberculosis skin test and interferon gamma release assays. It might be useful in patients who were already on immunosuppressive therapy, patients who are immunocompromised. So it will give additional information to tuberculosis skin test. Now you know how interferon gamma release assay is working. Who of you ordered quantiferon TB gold test for tuberculosis or had it ordered in the clinic? So you should know how does it work. Any patient with uveitis, we do radiology, chest X-ray, but we prefer CT chest because it is more informative. Molecular techniques such as PCR are not reliable. Unfortunately, we don't have, our Indian colleagues tried to have a PCR for tuberculosis, but it is not sensitive enough. So the imaging that we use for a patient with tuberculosis, we always do fluorescein angiography, ICG. ICG will allow you to detect choroidal involvement that clinically you will not be able to see it, and also fluorescein will not show it. Recently, we published a paper in journal I about ICG changes in patients with choroidal involvement in tuberculosis. OCT is useful, ultrasonography, and microperimetry. Now, what are the clinical features? In fact, tuberculosis is a great mimicker. It can produce any type of inflammation in the eye. It can cause acute anterior uveitis, chronic granulomas anterior uveitis, intermediate uveitis, vitritis, macular edema, retinal vasculitis, and chorioretinitis. It can cause choroidal solitary choroidal granuloma, multifocal choroiditis, serpiginous-like choroiditis, subretinal abscess, end of some mass, and band of some mass. I'm going to show you examples of all this condition. Retinal vasculitis is a very important feature of tuberculosis. Tuberculosis is the cause of the most aggressive occlusive retinal vasculitis. It is mostly obliterative periphlebitis, and it causes severe retinal ischemia. And if not treated properly, the patient will have vitreous hemorrhage, traction retinal detachment, and functional loss of the eye because of the occlusive retinal vasculitis. And this data are coming from one of our papers. And so in our series of patients, Anterior uveitis was diagnosed in 7% of the eyes, intermediate uveitis in about 13%, posterior uveitis 24%, and uveitis, of course, 56%. All the patients had a strongly positive tuberculous skin test, and the mean area of induration was 24 millimeters. These are examples. It is not enough to have hyperemia. You have to feel the induration. But this patient, it has, in addition, necrosis. This is also other examples of a strongly positive tuberculous skin test. In the anterior segment, bottom fat KPs, which is a sign of granulomatous inflammation, was present 35%, hypopyon in 6%, iris nodules in 8%, Bacillus synechiae is common, 20%, Rubiosis iridis because of retinal ischemia, because of occlusive vasculitis, and 3.5% cataract and pseudophakia. I'm going to show you a lot of examples so you will not miss a case of a case of tuberculosis in the clinic. Unfortunately, I don't have here pointer, but these are examples of bottom fat creative precipitates, which is a sign of granulomatous inflammation. Okay. Are they clear? Then we can have patients who can have something like this. This is tuberculous granuloma in the sclera. And in addition, the same patient had bottom fat creative precipitates. And this scleral granuloma responded nicely to antituberculous treatment, and after treatment, it resolved. Another patient with granulomatous creative precipitates. Now, this is an important case where you have, I'm showing a better example. Like this was a 16-year-old girl. She presented with multiple granulomas in the angle of the anterior chamber. There are two possibilities for this diagnosis, either tuberculosis or sarcoidosis. And several members of the family had pulmonary tuberculosis. So this is, again, another factor that you consider for the diagnosis. What is this? It's not copies nodules. This is more than nodules. This is a large granuloma on the iris. This is, you can call it nodule, but this is much bigger than nodule. This is a large granuloma. And again, if you see this, tuberculosis should be a possibility. And after treatment with antituberculous treatment. Now the vitreous, we had vitritis in about 60% and the snowballs in about 30%. And the snowballs that you can see here in the vitreous, these are usually very large. When I see this for me is a sign of ocular TB. Such large snowballs, and especially if it is associated with scars, because tuberculosis always leave bad scars in the retina. And frequently, these patients, they have cystoid macular edema. Macular edema is common among patients with tuberculosis and an important cause of blindness. Again, this is another case of large snowballs, and this is highly suggestive for tuberculosis. They are much bigger than the snowballs in the usual intermediate uveitis, and again, macular edema. Retina. Retina is affected by retinal vasculitis, which is always occlusive in 20%, neovascularization complicating occlusive vasculitis in 10%, and neglected cases, they will end like in diabetes with traction retinal detachment. Examples. These are classic cases of retinal vascular sheathing indicating vasculitis. In my lecture, previous lecture on retinal vasculitis, I told you this sheathing is corresponding to perivascular inflammatory infiltrate. And it is a sign of active vasculitis. And I also emphasize the importance that you should differentiate between, should be able to know the difference between active sheathing, indicating active vasculitis, and just sclerosed white vessels, which can be a sign of previous active vasculitis. This is a patient. In fact, he was misdiagnosed as branch retinal vein occlusion, but again, you can see very aggressive retinal vascular sheathing because of the severe vasculitis. And when you have severe vasculitis, you can have leakage of blood. These are other examples of vascular sheathing. This is actually not active vascular sheathing. This looks like sclerosed vessel as a sign of healed vasculitis, but the patient had ischemia. Again, another case of severe occlusive vasculitis. You see this sign, hemorrhage around the blood vessels, indicating severe ischemia. And if you do fluorescein, the fluorescein is showing severe retinal ischemia. If you don't treat this patient properly, the patient will end with fibrovascular proliferation, traction retinal detachment, and functional loss of the eye. This is a case. In fact, the vasculitis is not very active. It's becoming now like a sclerosed vessel, but the patient had, in addition, new vessels. If you do fluorescein, how is the retina? What are these? Huh? Yeah, but how is the perfusion? Retina is very ischemic. No blood vessels in this region. So the patient had advanced occlusive retinal vasculitis complicated with neovascularization. If you don't do laser and you give the patient proper treatment, the patient will end with blindness. I'm surprised that you are not able to identify ischemia. Do you agree that this retina is ischemic? Huh? Okay, more aggressive retinal vasculitis with hemorrhages, and a patient who had severe hemorrhage because of occlusive retinal vasculitis and neovascularization. This is an example of a patient, a 24-year-old male patient who presented to us with, what is this? Vascular sheathing, excellent. And what is this? New vessels. So, meaning that the patient had ischemic retina. And the vasculitis is occlusive. Now, wide field angiography, what do you see here? Severe ischemia. And here, ischemia. But why he had this hyperfluorescent spots? These are new vessels. So the patient had severe occlusive retinal vasculitis. Tuberculosis skin test was positive to about 24 millimeter in duration. So the patient was treated with full anti-TB treatment, but in addition, he received this. What is this? This is a scatter laser retinal coagulation. It is an essential part of the treatment, is to ablate the ischemic retina to prevent vitreous hemorrhage and traction retinal detachment. I heard PRP, this is not correct. The term pan-retinal coagulation is used when you give full laser in a diabetic eye. But here you apply treatment only to the ischemic retina. It is not full PRP, so it's better to call it scatter laser retinal coagulation. I heard sometimes, and I was reviewing one of the papers from the country, a colleague, he wrote that he does not do laser for retinal ischemia like this due to vasculitis because this can cause inflammation. This is wrong. You treat the patient with anti-tuberculosis treatment. We give also a short course of systemic corticosteroids, but you have to ablate the ischemic retina. So these are other examples, because vasculitis due to tuberculosis is the most common cause of retinal vasculitis in the country. So I'm showing you enough cases like here. I think now everyone in the room will be able to diagnose retinal vasculitis. And this is fluorescein angiography of this patient. And as I said, tuberculosis tends to cause very aggressive occlusive retinal vasculitis. That's why it can cause blindness. Do you agree that this retina is very ischemic? And looking here also, the whole peripheral retinal circulation is occluded. Now, what is this? Yes, ischemic vasculitis, occlusive retinal vasculitis can end with rubiosis iridis, and this, of course, will lead to functional loss of the eye. And what is this? Traction retinal detachment. This is, again, complicating neglected occlusive retinal vasculitis not treated in time. Now, we also reported that tuberculosis in the eye can cause optic nerve head infiltration. So optic nerve head infiltration can be seen in patients with sarcoidosis, in patients with leukemia. Leukemia causes optic nerve head infiltration, and also in tuberculosis. So this patient, he presented with right eye was normal, but the patient had severe optic nerve head infiltration. And for sure, we gave the patient, this is fluorescein angiography, and also he had edema, macular edema, subretinal fluid. But after full anti-TB treatment, we could recover the optic nerve with substantial improvement of vision. So optic nerve head infiltration also can be seen in patients with tuberculosis, uveitis. And after treatment, there is resolution of subretinal fluid. What is this? Choroid. Choroid is frequently involved by multifocal choroiditis, solitary granuloma, single granuloma, and serpiginous-like choroiditis. So I'll start with serpiginous-like. In fact, we always say that any patient who presents with serpiginous-like choroiditis, it is tuberculosis until proved otherwise. So like this patient, right eye was normal. The patient was referred to us with this. Why we say serpiginous-like choroiditis? This is to differentiate it from the immune-mediated serpiginous choroiditis. The immune-mediated serpiginous choroiditis is always localized around the optic nerve. But the tuberculous serpiginous-like choroiditis tend to be multifocal and even extending outside the arcades. In fact, our Indian colleagues, especially Professor Ahmed Gupta, they were the first to present this in the literature that this is TB, and that was almost like 15 years ago. So serpiginous-like choroiditis is a sign of tuberculosis. So like this patient, this is, and you can see here the choroiditis is spreading outside the arcades. This is not the same for immune-mediated serpiginous choroiditis that need only immunosuppressive therapy. These patients, they need full anti-TB treatment with a short course of systemic corticosteroids. And frequently, when this patient present to us, they show the combination of scars and active lesions. So part of that means that this is a progressive disease. All the lesions will scar, as I'm going to show you, and the fresh lesions will appear yellowish like this. So ICG is very informative. We publish this. The ICG will show you that the inflammation will destroy the choriocapillaris. Why? The ICG here is showing all these areas are black, they involved, because the choriocapillaris are lost. And this is after treatment. After treatment, we had the lesions scarred. We give the patient, of course, full anti-B treatment for 9 months and short course of systemic corticosteroids. And believe me, he ended with 20/40 vision. If you don't treat the patient at this stage, he will end with no light perception. This is another example. This she was, in fact, a medical doctor lady who presented to us with this right eye scars, meaning that she had previous choroiditis, but this is her left eye, the symptomatic eye. And you can see the aggressive choroiditis with areas of scarring. ICG similarly showed hypofluorescence corresponding to this area of choroiditis, indicating that there is complete loss of the choroid capillaries. And after treatment, the patient received a 9-month course of anti-B treatment with a short course of systemic corticosteroids. And these are also other examples of the disease. So serpiginous like choroiditis, this was very aggressive disease. And believe me, this patient was managed elsewhere with only immunosuppressive therapy. If you give a patient with tuberculosis uveitis only steroids and antimetabolites, they gave him Imuran and systemic corticosteroids, you will induce flare-up of the disease. You cannot treat a patient with tuberculosis with only immunosuppressive therapy. So this patient, this eye was almost lost. These are all examples of serpiginous like choroiditis. Now, these patients, they can have also multifocal choroiditis, as you can see here in this patient, with subretinal fluid. You can see here also scars and active lesions. Now, the other entity that we are also reported in this paper is multifocal choroiditis. So this, we call this multifocal. You see multiple patches of choroiditis. And if you can see here, some of them are scarred and some of them are active. And this is typical for these cases. They present with old lesions that are scarred and the fresh lesions that are not scarred and are yellowish in color. And if you do fluorescein angiogram, if you do ICG, the ICG will show you that each of these lesions is showing hypofluorescence. This is another example. This patient was referred to us by a neuro-ophthalmologist who thought this is optic neuritis. But he missed that this patient had also multifocal choroiditis. And frequently with posterior segment tuberculosis, the optic nerve head is inflamed. So this patient, in addition to having inflammation of the optic nerve, but the inflammation was second to tuberculosis because the patient had multifocal choroiditis. And the patient has also macular edema. And the ICG showed more areas of multifocal choroiditis than we could see clinically. Always the ICG will show you much more lesions compared to our clinical examination. This is another patient who presented with everything. Patient had, what are this? Huh? No, I'm putting the arrow on the iris. This is in the iris. Nodules. Of course, in addition to mutton fat KPs. So the patient had granulomatous and two-segment inflammation But in the pseudous segment, he had multifocal choroiditis in both eyes, which the lesions are delineated better with ICG. Again, optic nerve head inflammation and multifocal choroiditis. And ICG will delineate you the lesions, the choroidal lesions. That was another aggressive case of peripapillary choroidal involvement. Now we'll move to solitary granulomas. A patient can have a single choroidal granuloma, a melanotic granuloma, in a completely quiet eye. Clear vitreous, clear anterior segment. And this is frequently misdiagnosed as tumors, as melanoma. So there are two conditions that cause inflammatory solitary choroidal granulomas are, again, sarcoidosis and tuberculosis. Most of these patients were referred to our emergency room as intraocular choroidal tumors, melanoma. And we should be able, so there is a differential diagnosis of what we call it amelanotic choroidal inflammatory masses. I mentioned two of them, tuberculosis, sarcoidosis, and what? Inflammatory masses, amelanotic choroidal inflammatory masses, sarcoidosis, tuberculosis, and nodular scleritis. This is a differential diagnosis of inflammatory amelanotic choroidal masses. So like this patient was referred to us with the possibility of having choroidal tumor, most likely melanoma. But here, if you do ICG, it helps you to make the differential diagnosis because ICG will show you persistent hypofluorescence. And this is another case. And this is the OCT showing the mass. And on ultrasound, the A scan, it shows low to medium internal reflectivity. Another case. For ICG is typically showing hypofluorescence. They have edema also. And this is after treatment. This is one of the most recent cases. The patient had a large choroidal mass with overlying exudative retinal detachment. So this is the patient, and this is after antituberculous treatment. Years ago, I was in a meeting, and as a part of the meeting, there was a presentation of challenging cases. And a Turkish colleague was presenting a similar case. And I was very nervous during the presentation because he never thought about tuberculosis. And the case ended with inoculation. The eye was removed. And in histopathology, the diagnosis of tuberculosis was confirmed. So we don't want to have this. We have always to think about tuberculosis when we see such lesions. This is a recent case, a young Indian lady, and she had a large choroidal mass in the juxtapapillary area with inflamed optic nerve. And as you see, the ICG, as I said, typically will show that the lesion is hypofluorescent. And after anti-TB treatment, there was complete regression of the lesion. This is also another case. So it is common. So macular edema is common and is responsible for visual loss in patients with tuberculosis. In our study, 33% had macular edema. So you have to look carefully for macular edema. And these are examples of macular edema. And this is another case of granulomas anterior segment inflammation and cystoid macular edema. Same patient, if you do ICG, what are the findings in this ICG? Huh? Anyone can give an answer? There is multiple hypofluorescent inflammatory foci, and this is suggestive of choroidal granulomas. And this is the advantage of ICG because it can allow you to diagnose choroidal involvement in the absence of clinical signs of choroidal involvement. And that's why we published this paper on ICG on ocular TB. So this patient typically had many hypofluorescent dark spots corresponding to granuloma, which were not visible with fluorescein angiography or clinical examination. So the treatment, we need antituberculous treatment for 9 months. We can use, in addition, a short course of systemic corticosteroids to control the inflammation. And we cannot use corticosteroids alone because there are a lot of publications. This can lead to disasters. We use 4 drugs for 2 months: isoniazid, rifampicin, ethambutol, pyrazinamide for 2 months, and then we continue for another 7 months with rifampicin and isoniazid. We have few patients who were resistant, and we consulted the infectious disease. They added other drugs. We add systemic corticosteroids, 1 milligram per kg body weight, and the mean duration of using steroids in this patient was only 4 months. And then, to emphasize the importance of laser foot coagulation, we published this paper years ago in patients with occlusive retinal vasculitis that laser treatment is important. So patients with retinal vasculitis, if you have a patient who presents, this is a summary of this paper. If you have a patient presenting with active retinal vasculitis, but the retina is not ischemic yet. So here you need to treat only medically, antituberculous treatment and systemic corticosteroids. A fluorescein angiography shows that in addition to active vasculitis, active vascular sheathing, that there is ischemia, then you need to add laser foot coagulation. If the patient bleeds, if the patient develops vitreous hemorrhage, you should not wait long before you do vitrectomy, because the earlier the vitrectomy, the better the outcome. If you leave the patient for several months, then the fibrovascular proliferation becomes mature and it will be very difficult to dissect. So I'm going to show you examples of treatment. This is a patient who presented with granulomas inflammation of the anterior segment, and this is after completing a course of anti-TB treatment. This is also another example of granuloma of the angle of the anterior chamber. And also here, another example of multiple granulomas in the angle and after treatment. Please note that most of these patients have also pseudoscianicchia. Presence of broad pseudoscianicchia is also suggestive of tuberculosis. Again, before and after treatment, cystoid macular edema, as I said, is common, and after anti-TB treatment and steroids, it will resolve. Another case. So these are cases of serpiginous-like choroiditis before and after treatment. After treatment, you see resolution of the active choroiditis. But of course, tuberculosis tends to leave very bad scar, chorioretinal scar. So this is the patient that had peripapillary, very active choroiditis, and then after full anti-TB treatment and steroids. So this is another case with solitary nodule, a melanotic choroidal mass, and after anti-TB treatment. So this is the case with what do you expect to have here if you do fluorescein angiography? Ischemia, because you can see here the new vessels. Let us see. This is fluorescein, very ischemic retina. And this is the pattern of laser that you apply to the ischemic retina. And of course, these are the new vessels. So this is after good scatter laser treatment, there is regression of the new vessels. This is the same patient that we discussed earlier, vascular sheathing, new vessels, severe retinal ischemia, and after laser treatment, then you can save the vision of the patient. So this is a case that progressed into fibrovascular proliferation and vitreous hemorrhage. So this patient needs vitrectomy. And at the time of vitrectomy, we add laser treatment. So just to show you that at the end of the follow-up, the visual acuity improved in these patients, and also macular edema. So in conclusion, in recent years, ocular involvement due to tuberculosis has re-emerged. Tuberculosis uveitis is a treatable disease. In fact, I feel happy when I make a diagnosis of tuberculosis uveitis because I know that the patient will receive the course of anti-B treatment and is cured. It is not like patient with Behçet will continue with you having the treatment for years. So tuberculosis uveitis, you give anti-B treatment, 9 months, and then the patient is cured. So you don't need to have long follow-up for these patients. A high index of suspicion of the diagnosis should be maintained in patients with unexplained chronic uveitis. Treatment with anti-tuberculosis therapy combined with systemic corticosteroid induces resolution of inflammation with no recurrences. When you treat this patient properly and they have the full course of the treatment and you stop the treatment, the inflammation will not recur again. And this induced significant improvement of visual acuity and macular edema. Thank you very much for your attention.